Hello, everybody. My talk today is on prevention of congenital CMV. Is maternal treatment the solution? These are my conflict of interest. So CMV is the most frequent cause of congenital infections with a worldwide prevalence of 7 for 1,000 births and a prevalence in Europe of 4 for 1,000 births. So it's the most common non-genetic cause of hearing loss and the major contributor to permanent neurologic disability in children. Fetal infection may occur after 3 types of maternal infection, either a primary infection or reinfections because CMV immunity is incomplete. And also there are high genetic diversity among CMV strains, and we can be reinfected with a different strain. And reactivation of the endogenic latent strain is also a possibility. So all these type of infections are responsible for maternal viremia, placental infection, and transmission to the fetus. That is 30 to 40% in primary infections, poorly documented in non-primary infection, probably around 4 to 5%. So it's important to understand that non-primary maternal infection, either reinfection or reactivation, explains approximately 50% of congenital CMV infection in European countries. So among women with primary infection, only those with a primary infection in the first trimester represent a high-risk group of severe fetal infection. And this is confirmed in a meta-analysis of the literature, including 17 studies. So the risk of complications during the natural course of congenital CMV following a maternal infection in the first trimester is high. Among 100 neonates infected after a maternal primary infection of the first trimester, 23% will have hearing loss, and 32% will have neurological sequelae. These slides shows you the risk of long-term sequelae according to the type of maternal infection. 3 studies tackle this issue, and an American study from the team of Birmingham, Alabama. They screened more than 100,000 neonates, and they found a proportion of hearing loss of 10% following maternal primary infections and 11% following maternal non-primary infection. Our group in France, we screened nearly 12,000 neonates, and we found 12% hearing loss following maternal primary infections and 19% following maternal non-primary infections. In Brazil, where the pregnant women are nearly all seropositive for CMV, the group from Pinhata screened 11,000 neonates, and they found 13% of hearing loss following maternal non-primary infection. So the risk of hearing loss is similar following maternal primary infection or maternal non-primary infection. So the prerequisite to prevention of mother to fetus transmission is, of course, to be able to identify the maternal infection. And this is feasible for primary infection in the first trimester, as we can do this diagnosis based on CMV serology, but yet it's impossible for non-primary infection, which you remember represent 50% of congenital cases in most European countries, because there is absolutely no tools validated to do the diagnosis of non-primary infection. So at the population level, only half of congenital CMV cases with sequelae could be avoided with a prevention targeting maternal primary infection in the first trimester. So preventive treatment should rely on drugs efficient to prevent CMV vertical transmission, and safe to use in the first trimester of pregnancy. So far 2 options have been studied: the use of anti-CMV drugs, mainly Valacyclovir, and the use of hyperimmunoglobulin. Why Valacyclovir? So the most efficient anti-CMV drugs available are ganciclovir, foscarnet, letermovir, and maribavir. And in vitro, valacyclovir is the least efficient drugs against CMV, as you can see here from a work from an Australian group. They test the efficacy of antivirals in CMV-infected first trimester extravillous trophoblast cells. And they found that the half maximum effective concentration were low for ganciclovir and letermovir, but were quite high for acyclovir. So acyclovir can be efficient in vitro, but only at high dosage. And in clinical practice, it was shown indeed that the prevention of CMV disease in allograft recipients with high dosage valacyclovir, 2 grams 4 times a day, was efficient. Moreover, valacyclovir has the best known safety profile among CMV drugs, with no genotoxicity, no carcinogenicity reported, no teratogenicity in most studies, except in one recent study where the authors reported birth abnormalities in around 10% of rats treated in the embryonic period with a dosage 4 times higher than the peak concentration observed in humans treated with 2 grams 4 times a day. And there are reassuring safety data in human pregnancy at all stages, and the tolerance of acyclovir is good. In comparison, ganciclovir has shown genotoxicity in vitro, is teratogenic in animal models. There is no safety data in human pregnancy, and the tolerance is not so good with frequent neutropenia. Letermovir and maribavir are very new drugs, and no safety data are available in human pregnancy. In our group, we've been using valacyclovir in women carrying an infected fetus since around 10 years. We first did a phase 2 multi-center study, open label. All included women were treated with valacyclovir 8 grams per day from positive amniocentesis up to delivery. And the outcome in the first 43 treated women was compared to an historical cohort. And this comparison indicated that valacyclovir significantly increased the proportion of asymptomatic neonates from 43% without treatment to 82% with treatment. So we've now used valacyclovir in 150 women, and with no side effect, except headaches reported in around 3% of treated women, leading to temporary interruption of the treatment. An Israeli group, based on this result, an Israeli group designed a randomized double-blind placebo-controlled study to prevent vertical transmission using valacyclovir. In this study, they included 90 women with primary infection in the first trimester or the periconceptional period. 45 women were treated with 8 grams per day, 4 grams twice a day until amniocentesis, and 45 women were treated with placebo until amniocentesis. The primary endpoint of this randomized study was the transmission rate evaluated by CMV PCR in amniotic fluid collected by amniocentesis. As you see here, the results are very striking. In the total population, there was a significant reduction of transmission from 29% in the placebo group to 11% in the treated group. And in the population of women with a primary infection that could be dated In the first trimester, there was also a significant reduction of transmission from 48% in the placebo group to 11% in the treated one. However, in the population of women with primary infection in the periconceptional period, no significant reduction of transmission was observed, with 12% of transmission in the placebo group compared to 11% in the treated group. Another important information from that study is that the time for presumed date of maternal infection to initiation of treatment was significantly longer for treated women who transmitted the virus, 75 days, than for treated women who did not transmit the virus, 50 days. This suggests the importance of implementing the treatment as soon as possible after the onset of primary infection. So since the release of the result in October 2019, all cases of maternal primary infection of the first trimester referred to our center before 14 weeks were offered Valacyclovir treatment. So we analyzed the efficacy of this preventive treatment comparing transmission rate to a historical group within a case control study using a propensity score. So we treated 65 women, and the match control, we had 65 match control. The rate of periconceptional infection was similar in the two groups. The gestational age at amniocentesis was 18 weeks in match controlled and 17 weeks in cases. The median duration of Valacyclovir therapy was 35 days in cases. Of course, the controls were not treated. The gestational age at initiation of Valacyclovir therapy was 12.7 weeks. And the rate of positive CMV PCR in amniotic fluid was 29% in the controls and 12% in the cases. So the results we obtained in this case control study were very similar to those described by the Israeli group, with a significant decrease of transmission in the whole population from 29% to 12%, an efficient decrease of transmission in women infected in the first trimester from 45% to 19%, but non-significant decrease in the periconceptional group. So after the publication of the Israeli study, we switched from a dose regimen of 4 doses of 2 grams to the dose regimen used in the randomized control trial of the Israeli group of 2 doses of 4 grams. So we had the surprise to observe 2 cases of acute renal failure in the 50 women treated with the 2 doses regimen. And when we did, we never observed acute renal failure in the 172 women who were treated with the 4 doses regimen. So I want to insist on that, to stress that it is absolutely crucial to recommend hydration of the patient, and to control renal function once a week. The other option to prevent vertical transmission, is to use hyperimmunoglobulin. And this is based on a body of evidence from in vitro and animal studies showing a reduction of transplacental passage of CMV in the presence of neutralizing antibodies, and based on one observational clinical study suggesting an efficacy of hyperimmunoglobulin to reduce fetal transmission in pregnant women with primary infection. Since these early studies, an Italian randomized control trial could not show a significant reduction of transmission, using hyperimmunoglobulin with 50% of newborns infected compared to 44% in the placebo group. And a randomized control trial done in the United States was stopped in 2018 for inefficacy. And the transmission rate was 23% in the treated group compared to 19% in the placebo group. So the failure of these two trials is challenged by the data from a German group, and they published the result of the first study in 2019. It was a prospective observational study. They selected 40 cases of very recent primary infection in the first trimester, and they observed a 7.5% transmission rate compared to the 35% observed in a historical group. But there were differences with the previous studies. First, the German group used a higher dose of immunoglobulin, 200 international units per kilo compared to 100 in the two randomized trial. And moreover, they use more frequent injection to respect the short half-life of immunoglobulin. So it was a bi-weekly injection in the German study compared to a monthly injection in the randomized control studies. Moreover, there was a much shorter median time interval between diagnosis and first immunoglobulin administration in this study. Recently, the German group published a confirmatory result from also an observational study, but now they've been treated 165 women with a very good result of less than 7% of transmission in those women treated after a primary infection in the first trimester. So for efficient prevention, timing is everything, and this is probably explained by the physiopathology of primary infection in pregnant women. After an incubation of 3 to 4 weeks, viremia occurs from week 3 to 4, and IgM are detectable from week 4 to 5. Placenta infection may occur from week 4 to 5 or later, and then transmission to the fetus. So primary serological diagnosis is only possible from week 4 to 5 when IgM have appeared. So with a 7 to 10 days serological window, the placenta fetus might already be infected even before the maternal serology is positive. So this stress the importance of treating the infection as early as possible. So the question was, prevention of congenital CMV, is maternal treatment the solution? I think yes. I think that we have the means to treat these women who have a primary infection in the first trimester. Maternal treatment with Valacyclovir at high dosage is efficient to prevent vertical transmission in the first trimester, as shown in this wonderful study from the Israeli group. And studies, although not randomized, suggest also a similar efficacy of hyperimmunoglobulin. Of course, there are limitations. Prevention treatment should be started as early as possible after the onset of maternal primary infection. And that means that we need to be able to do the diagnosis of primary infection very early in pregnancy. So this means early systematic CMV serology screening that should be organized to identify women with primary infection in the first trimester. And yet no countries have screening programs for serological CMV in the first trimester. Moreover, efficient tool for the diagnosis of maternal non-primary infection should be developed, because as we've seen before, the CMV serology cannot detect maternal non-primary infection. So we're not able yet to diagnose those infections, and as we can't diagnose them, we of course cannot prevent vertical transmission. Thank you for your attention.